as expected for early stage Parkinson's patients treated with medical, medications, everybody worsened.
And if that hyperkinetic output is driving neurodegeneration, we've had FDA approval to lead a large-scale phase 3 trial, a pivotal clinical trial.
But I do think your question about where would we be in 10 years, I think that's really interesting. Hopefully by
then. Welcome to Stimulating Brains.
Mallory Hacker is an assistant professor for neurology in the team of David Charles, who is professor of neurology, vice chair for business development and strategy, as well as the medical director for Telehealth at Vanderbilt University Medical Center in Nashville, Tennessee. In 2006, after a stay with Alim Louis Benabids in Grenoble, France, David started to investigate the question of whether subthalamic DBS could lead to slowing of motor progression in patients with early stages of Parkinson's disease. In a one-of-a-kind trial, he collected data on the first patients, which were published in 2014. In subsequent follow-up trials, many of which were first authored by Mallory Hacker, Class 2 evidence that supports this hypothesis could be established. It was a great joy to host Mallory in my lab in Berlin in 2022, and we have looked at the effects of lead locations on patients enrolled in this pilot trial. This is what convinced me that there might be something. The few patients that did not progress at all in their motor symptoms after 2 years were all precisely stimulated at the optimal location within the SDN, while the ones that did progress were more off-target. Indeed, these same optimally placed patients had lower stimulation amplitudes and received less medications, but still had a clearly better outcome. Since that original trial, David and Mallory have been hard at work in trying to secure funding for a phase 3 pivotal trial, and we discuss how difficult this process has been, but also that there is hope on the horizon regarding the next steps. So, David and Mallory, I'm super honored to do this podcast with you about, I think, a very exciting topic. And we have been collaborating. I will have introduced you more formally by now, or we will have. So we can jump right in. And to break the ice, I always ask about hobbies and free time. So this is a question to each one of you. Maybe Mallory can start. What do you do when not involved in research or medicine?
Yeah. So first off, thank you so much, Andy, for this invitation. It's really an honor to be here. So I actually have a two-part answer. So I have the answer I would have given if asked the question 5 years ago. My husband and I, we like to stay active. So we have recreational kayaks that we take around Nashville. We have a couple of road bikes. We enjoy hiking and travel. And any opportunity to combine hiking, biking with kayaking and travel is really made for some of the more memorable trips that we've had. But more recently, we've become parents. We have two small boys at home, a 3-year-old and a 1-year-old. So we don't have the opportunity to do as many of those activities anymore. So our free time now is really spent at playgrounds and pools and going to the zoo. But fortunately, our boys are getting a bit older. We've already taken them on a few family bike rides. And so we're looking forward to returning to our former hobbies with them as they get older.
Sounds great. David?
Well, my response is somewhat similar. So our boys are now grown, and my wife and I are empty nesters. But we have 3 grandchildren now, and they live just about an hour from our home. They previously were a long distance away from us, but now they're nearby. And so spending time with them. And then the other activity for me is exercise. And I think COVID, in a way, in 2020 transformed that for me. And it's something that I've continued after. So It's a great outlet and certainly makes you feel so much better after you do it.
Yeah, fantastic. That sounds great. And I remember loosely, I don't know where we met, but I think you once also took care of one of Mallory's kids for an afternoon or something, right? So that has happened. That impressed me. So
It's a testament to Mallory that she would trust me with her son.
yeah, fantastic. And then also, general starting question, diving into careers. Who were key mentors in your careers and turning points? And maybe we start with David here, because I assume that David is one of the key mentors for Mallory. But so how did you get where you are now, David?
Yeah, so two names come to mind right away. The first is a fellow named Riley Reese, a plastic surgeon. As an undergraduate at Vanderbilt, I was an engineer and had a work-study job in his laboratory. And as a sophomore, one day he grabbed me out of the lab and said, "Come on to go on rounds with me in the hospital." And I had previously had no interest in medicine, and obviously here I am today as a physician. So his mentorship was transformative for me. The second person is Alim Louis Benabids. I had the opportunity to serve as a Fulbright Senior Scholar in Grenoble, France, with Professor Benabids and also Pierre Pollock, and it was there that Professor Benabids said to me, sort of in an offhanded comment in the changing room in the OR, that he felt that if we applied DBS in very early stage Parkinson's, that it would slow the progression of the disease. And being a typical neurologist, I scoffed at that. And but while they're studying there, I had a chance to review their videos, and I could kind of see what he was talking about in some of their patients. And so that moment, which is still very memorable to me today, was obviously also transformative as I returned to the United States in around 1999 and began trying to answer the question: if we apply DBS in very early stage Parkinson's, would it slow the progression of the disease? So I in this project am like a project manager. The intellectual original idea is Professor Benabids.
I did not know that. That's an interesting fact. And how long did you spend time in Grenoble? 1999, you said?
Yeah, it was in 1998 for 6 months. So the second half of 1998. We loved it so much, we literally flew home to the U.S. on the day our visas expired. If our flight had been delayed, we would have been in trouble.
It is a great place with the mountains and everything, and I'm sure that the science at the time was great in Grenoble, of course. Really, really interesting. I remember he gave a talk much later, just recently, maybe 2 years ago, about also some light therapy. Maybe we can talk about that later if it comes up. But yeah, and then Mallory, for you, how did you end up at Vanderbilt doing what you do now?
Yeah. So I've been fortunate to have, kind of key mentors at really great kind of stages in my career. So the first one was how I got into research. So it was actually my undergraduate biochemistry professor, Manuel Santiago, who encouraged me to consider a career in medical research. I grew up in a very small town in West Tennessee that did not include biomedical researcher on career day. So it was really great, at that pivotal time in college to have not only that exposure to research, but also that encouragement that it might be a career that I could really thrive in. And then the second one more recently that you've already alluded to, Andy, is of course David Charles. So he was my postdoc mentor. We started working together 11 years ago. Obviously, we still work very closely today. And he's, throughout this tenure has been, just a wonderful mentor as I not only entered clinical research, but also the field of neuromodulation for the first time.
Fantastic. Okay, so David, in 2014, so 10 years ago, roughly, you published a first report on the DBS in early stage Parkinson's disease study. Can you tell us a bit how the study came about at the time, and then briefly summarize how it was designed, what you found?
Sure. So upon returning from Grenoble, I set the goal of trying to answer the question that Benabids had, and that was, if DBS was applied early, would it slow the progression of the disease? And so from 2000 until about 2006, it took that long to get FDA approval. It took more than a year to get FDA approval and required a face-to-face meeting, and some interesting stories from that. And then to garner the funding to do the study. And it was cobbled together from an industry sponsor and from my university and such. And so all of this seems to take much longer than it should, but we successfully completed the only FDA-approved trial of DBS in very early stage Parkinson's disease. And when I say early stage, what I mean by that is of the 30 participants in the study, the average duration of illness was only about 2 years, and they couldn't have had dyskinesia or other motor fluctuations. They had to be in essence stable responders. The study had a unique design. Andy, we don't have a biomarker for tracking the progression of Parkinson's disease, and so our trial, in lieu of a biomarker, used a washout, and that washout is 7 days. So at the beginning, at baseline, patients washed out of medications, and a baseline assessment was made, videotaped, so that the outcomes could be at least single blind. The video recordings scored, and then they proceeded into the study, randomized to either receive deep brain stimulation and standard medical therapy, or medical therapy alone. And they returned every 6 months for an inpatient stay to wash out of all therapy. So the DBS group, we turned off their devices and stopped their medicine. The medicine group, obviously, we stopped their medicine, and they washed out. And so that was completed 5 times. So at baseline, and then every 6 months for 2 years. And so that in lieu of a biomarker, that week-long washout really approximates the virtually untreated. You'll always be able to find folks out there that point to publications that medications can last 2 weeks or longer. That's true, but the great majority of the medications have washed out, and we learned during the study that the group that had DBS took way less medicine, and so if there was a lingering medication effect, it would have favored the medicine arm, and our findings would have been diluted. So the washout, has proven to be a very robust method in lieu of a biomarker. The main findings of the first trial, the goal was set out to discern if it was safe and tolerable. And so the study met its primary endpoints. And what we really demonstrated is, there were so many critics at the time. 95 out of 100 movement disorders experts at the time thought we were crazy for doing this study. And some thought it was unethical. But the ethicist at Vanderbilt thought it was ethical and convinced the FDA of the same. And so we showed that it was, met the primary endpoint, that preliminary safety was there. Subjects tolerated the study procedures. But what we showed, more importantly in my mind, is that we demonstrated that, yes, you can recruit people with very early stage Parkinson's to enroll in a study where they may have accept significant risk. It's an operative procedure to implant DBS. It carries significant risk, albeit a small chance that something would go wrong, but something could go wrong. We demonstrated not only could we recruit people to enroll in the study, but that they would stay in the study. So over a 5-year follow-up period, we only had 1 participant drop out of the study. And that's remarkable. And I really attribute that to the informed consent process that was used. So our biomedical ethicist, Stuart Fender, developed a 3-part informed consent process that was based on a separate project he had led here at Vanderbilt in maternal fetal medicine, where they were operating on fetuses in utero to close spinal cord defects. And he modeled our informed consent process after that one that had proven to be so successful. And our trial, obviously, was so successful as we only had 1 person drop out over a 5-year period. So that I think that's really the main findings of that study.
Fascinating. And you did, since you mentioned the anecdotes that could be shared with the FDA, anything you want to talk about there, like in that process of getting it FDA approved?
Oh, well, yeah. So we spent a year going back and forth with our primary contact at the FDA, and they had, understandably, serious concerns about this, operating on people with very early stage Parkinson's. We had lots of critics in the field, and so finally we requested an in-person visit, and we took our whole team up: a surgeon, myself, our biomedical ethicist, other neurologists at Vanderbilt, and the FDA brought their team to the table. And it was the biomedical ethicist that carried the day. The FDA was arguing, why don't you study this in mid-stage patients? And the biomedical ethicist, shared, that if you wait until someone's mid-stage, the dopaminergic neurons you're trying to save are largely gone. If a person first presents with Parkinson's disease to their clinician, and let's say it's estimated that 50 to 70% of dopaminergic neurons in the substantia nigra have already degenerated, then operating on people in mid-stage could have a therapeutic effect, symptomatic, but the cells you're trying to save are no longer there. And so here's what the ethicist argued, and it stopped the room, and it changed the mind of the FDA, and they approved the study. Here's what the ethicist argued. The ethicist argued that if you force the Vanderbilt team to study this in mid-stage, then you're exposing all of those mid-stage patients to the risk of surgery, and you will not answer the question. Then you'll have to do the study in the early stage. So at the end of the day, you're forcing the Vanderbilt team to expose more people than is necessary to the risk of surgery. And that argument and that face-to-face meeting, we received approval soon after.
Sounds great. Yeah, that's very insightful. And I guess, if it were true, if we knew, then it would even be potentially unethical to not offer the therapy, of course. So there's certainly the flip argument to be made there too. Great. So maybe just for the listeners, that to clarify one more time, you said it already, but this was very early stage, because there's the early stage trial in that's been published in the New England Journal, and that's very different from yours. Maybe you can briefly differentiate one more time between the two.
Yeah, it is confusing because that trial's named Early STEM, right? And we're studying DBS and early stage Parkinson's disease. So the Early STEM trial, was, in my mind, an outstanding trial. We were not part of that at Vanderbilt. It was carried out in Europe, but it's an outstanding trial. We could talk about that later. But, our trial was conducted before the Early STEM trial. And so our inclusion criteria were people had to have been on Parkinson's medications longer than 6 months, but less than 4 years, and they couldn't have levodopa-associated dyskinesia. They had to be stable responders. And as I said before, after the 30 enrolled, on average, the cohort had Parkinson's about 2 years. The Early STEM study, what they wanted to do was study people earlier, and at that time, FDA approval and European too was for advanced stage Parkinson's. So the early STEM cohort, they had to have had the illness longer than 4 years, and they had to have the presence of levodopa-associated dyskinesia. So by definition, that cohort is mid-stage patients, and our cohort is very early stage patients. The findings from Early STEM, though, are so compelling. So in my mind, what an outstanding study.
Fantastic. And so we should briefly mention that in your trial, 2 of the subjects suffered adverse events. Can you briefly talk to that?
Yes. We had one participant who post-operatively had weakness in a limb, and post-operative CT showed a small collection of blood at the tip of the electrode. That weakness, a little bit, I think he had a little bit of facial droop and drift in one arm. That resolved over days and weeks, and so didn't have sequelae after. The other one we had to report as an adverse event, but so this gentleman, it's actually a good story. This gentleman responded so well to DBS, and his favorite hobby was, working on an old car that he was restoring. He and his son or grandson, I believe, were in the garage working on this car, and somehow or another, the garage door was lowered onto his head, hit him in the head, and right across where the lead on one side was, and it caused a a laceration in the scalp, and he ultimately had an infection and required explant of his therapy on that side. And then once we cleared it all up, then it was reimplanted. Part of me wants to take credit for the fact that he was doing so well. He was out there working on his car in his garage. But anyway, that one, that counts against us. I guess as an adverse event. Certainly, infection of the device is something that's known to be possible to occur, and it did in one of our participants.
Got it. And how was the study perceived by the field? You mentioned there were a lot of critics before. When it came out, what did people think?
Andy, it's been quite a journey. At the beginning, the criticism, as I said before, it seemed like 95 out of 100 people in the Parkinson's community were against us, and the criticism at times was pretty harsh. In fact, a little bit at times it even turned personal. Now, the study published in 2014 really began to turn the tide, and so now today, is 95 out of 100. Feel that this study has to be done. More than 30 centers across the U.S. have completed site qualification questionnaires and have expressed their interest in being in a large-scale phase 3 study. There are still people good minds, can disagree. There's still outstanding people in the field that don't believe that DBS in early stage should be studied, and they're certainly entitled to their opinion. But the tide has certainly turned, with the large majority of the field now squarely in the camp that this question needs to be answered.
Great. I very much agree, and we'll get into that a bit more as well later. So Mallory, you must have joined the team a bit later, although I think you mentioned it was around the same time maybe the paper came out. But how did you come across the work, and how did you become excited about it?
Yeah, so it was really serendipity that kind of brought me into this project. I was finishing up my PhD work at Vanderbilt. I was in a basic science laboratory studying neurodegeneration that arose from coenzyme Q deficiency, but I was doing it in C. elegans. And kind of at the end of my graduate school, time, I had decided that I wanted to transition into clinical research for a career. That's obviously quite a bit of a leap from C. elegans neuroscience into clinical trials. And so I was really looking for opportunities at Vanderbilt to get exposure to clinical research. And so I just did a very simple internet search for Vanderbilt clinical research internship. And out of that search popped up this neurologist at Vanderbilt, David Charles, who at the time was leading an internship program for clinical research for undergraduates. So I just sent him a quick email, briefly explaining kind of my situation and what I was looking for, and asked him if he knew of anyone that I could reach out to that might have an opportunity for me to learn a little bit about clinical research. From that email, he invited me to come meet with him, and that's where I first, learned about what he was studying, what his clinical practice was, and his research interests. And it was in that initial meeting where I first learned what DBS even was, right? I just had not come across, my path personally or academically. And, just thinking back, we can all remember the first time we saw videos of patients with Parkinson's before and after DBS. It's very striking. So it was clear in that first meeting with David that he was, working with a very powerful therapy, and he was one of the pioneers at Vanderbilt who brought DBS, forward. So he then went on to explain, like I said, you just mentioned the timing. So they had just completed the 2-year trial when David and I met. And he explained that they just, led the only FDA-approved study testing DBS in patients with very early stage Parkinson's, with the overarching goal to see if it could slow progression. They were at this really unique transition point where they were looking ahead to lead the next study, so lead a multi-center, double-blind, pivotal clinical trial. And that was really kind of where the team was at the time. And David mentioned that he actually had a position open, so a postdoctoral position open on his team. So, it sounded like a really great project that would not only give me the exposure to clinical research, on a really, a project ready to launch that I was looking for, but scientifically, for this basic scientist with an interest in neurodegeneration, it was a super interesting project.
Yeah.
So, I took the leap and joined David's group as a postdoc, and we've been working together ever since.
Fantastic. And the first key paper you published on the trial was, I think, the 2018 neurology article, followed then 2 years later by the 2020 article in the same journal. And you were first author in both, and David was last author in both. Can you summarize these two papers for us?
Sure. Yeah. I mean, those two
findings.
papers were really exciting for us because they started to provide, hints that there might be some disease-modifying potential here. For the 2018 neurology paper, it really, arose from me asking the question, thinking back to that 1 week washout that David mentioned. The intention to treat analysis looked at the end of that washout, the Unified Parkinson's Disease Rating Scale Part 3, which is a summation of many different motor symptoms of Parkinson's disease. And so I just had the question of whether, were we missing some effect of DBS by grouping all of these motor symptoms together? So were there individual motor features for the early stage patient whose progression might be more affected by DBS than others? And so I just broke down all the items of the UPDRS, looking at this progression score, and this is where rest tremor popped out. So for the control patients just treated with standard medical therapy, we saw, this steady progression from baseline and every 6 months over 2 years. And then when we looked at the DBS patients, it was just a flat line, right? So there was essentially no progression across the group over 2 years. And this led to a very, kind of a dramatic difference in slopes that was, really quite exciting to see for the first time. We then took that result and brought it to Malin DeLong, who, as you all know, unfortunately recently passed away, but he was a luminary in the field of Parkinson's disease and DBS, and was a supporter of David's, this project for many years. And he was the one who recommended that we not only look at the difference in slopes as we had already done, but also to see if there was any effect of early DBS on the spread of tremor. So as mentioned up until then, we used this item score for tremor, which is basically a measure of severity. So it sums all the limbs and the head and gives a measure of severity of tremor. But Dr. DeLong thought it was, also very important to see if DBS was slowing the spread of one of these cardinal features of Parkinson's. And so what we mean by spread is essentially, Parkinson's symptoms can arise in a single limb, and then as the disease progresses, more and more limbs can be affected by these motor symptoms. And so sure enough, when we looked to see how tremor spread might have differed between the randomization groups, it emerged in a new limb in almost every single control patient, but less than half of DBS patients had new tremor emerge over the course of the trial. So the difference in slopes that we saw and the difference in spread, were very pronounced and very, exciting for that paper. One thing we also included there, which I think is really important, is results of a patient satisfaction survey that David and colleagues had done right as the trial concluded. So every person in the trial was just asked very basic, open-ended questions about what it was like to be a part of the study. And one of the questions there was asked the DBS patients, what's been the greatest benefit of undergoing DBS surgery? And again, it was an open-ended response, and we saw, looking back after we discovered, this potential effect on rest tremor progression, that half of the people who were randomized to DBS said that tremor benefit was the greatest part about undergoing DBS surgery. So it was really nice to see the convergence of this blinded 1 week washout score pointing to rest tremor, and then the patients themselves were the ones that told us that tremor was the most impactful for them in the early stages of the disease.
Super cool.
Would it be
Go ahead,
okay if I
David, yeah.
jump in and just
Of course,
add
please.
something to
Yeah.
this? So, this finding is so exciting to me. I can remember when Mallory shared it with me. Because here's what comes to mind. In people with early stage Parkinson's disease, tremor is not disabling. It is distressing. And when you read about the impact of tremor in people with Parkinson's disease, particularly in early stage, it's remarkable what the patients tell us about how incredibly stressful it is. The attempt to hide the tremor, to not let others see it, to do anything and everything, because tremor is so visible in it, and people feel that maybe it makes them appear frail or that they're failing. And then, Malin's idea to look at spread was just genius. And when I reflect on it, it's so true for the patient, because the patient, let's say they develop tremor in the left hand, and then it spreads to either the left leg or to the right hand. Spread in medicine is bad in every case, right? If you think about cancer, the idea of spread, right? And so the distress that people feel with tremor in early stage, and then the added stress of when it begins to spread, it tells them, it shows them, and it shows their family and their colleagues that their disease is progressing, relentless progression. And I have learned from listening to patients, and we've published on this topic, about how incredibly distressing tremor is in early stage Parkinson's.
Yeah. I'm sure. I want to pause and step back one more time just for the listeners. This is a podcast. If people are new to the topic, just to reiterate, the study design was, you always took the scores at baseline before surgery, and then you took them after a week of stopping any medication. That's what we call the washout phase. So after that 7 days washout, you took the score. So we can compare these two time points before surgery and 6 months after, and then 12 months after, and assume that in that week there was no medication, so the patient was back to their normal normal state as they would have been without any medication. Of course there are caveats, you went into that. Just to mention that one more time, because I think that's so critical about this trial, that no other trial did this that way, right? And that's why we also, I think, can't use any other DBS experience to say anything about the topic, because we never have that washout phase, right? So I think that's very, very important just to reiterate. And so in that 2018 paper, it was probably the first real hint that there might be something to it, and it was mainly focused on tremor. And I can only imagine what a eureka moment that must have been for you, for after this long time of, since 2006 you said you started, so 12 years of work, and then there's a glimmer of this might be real. And I mean, tremor is one of the first symptoms, right? So it makes sense that tremor is the most salient feature here as well. Yeah.
Agreed.
Mallory, I did also ask you about the 2020 trial, and the same question. Maybe we can briefly cover that too, because that was the 5-year follow-up.
Sure. Yeah. I mean, I think that's also a really important paper, because, at the time it was the longest, published follow-up from a randomized clinical trial of DBS at any stage in Parkinson's. Now, while it was a small pilot study, 30 people joined. As David has already mentioned, it had exceptional retention. So we had a really robust data set to look at, with 29 out of the 30 people completing both the 2-year trial and 5-year follow-up data. And so what we saw there was really long-term benefits with early DBS in reducing the amount of medications required, both in the levodopa equivalent daily dose, so the amount of medications, which we know ST and DBS can reduce. We've seen that in advanced Parkinson's, but also a reduced need for polypharmacy. And so what we mean by that is requiring more than one class or type of Parkinson's medication to manage symptoms. And that polypharmacy result at 5 years followed up on what we've seen in an analysis that we did at 2 years, where we saw this difference. So that kind of brought that finding out through 5 years. Obviously, based on the 2018 paper, we had an interest in looking for to see what happened long term in the context of rest tremor. And so we also saw a long-term benefit on the symptomatic control of rest tremor for the early DBS group. And another key finding of that 5-year paper that I think is important to talk about is it was really the first time that we had a good chance to see how early DBS might influence dyskinesia. David already mentioned that the pilot study by design excluded people who had dyskinesia. We wanted to study the early stage patient. And, the trial was a 2-year study to the primary endpoint. And we already mentioned that they were very early in their course of Parkinson, so just average of 2 years disease duration. So at the, kind of the primary analysis, 2 years after the trial started, there wasn't really enough emergence of dyskinesia across the cohort to see if there was any difference between the groups. But now that we had a 5-year data set, we could start to see, this difference emerge. We saw that control patients were 2 to 3 times more likely to have a greater presence and severity of dyskinesia than the early DBS subjects. This missed a significance threshold just barely, but when you consider this result alongside what I mentioned, that we saw this, notably reduced medication requirements, reduced need for polypharmacy, I think it's a really intriguing signal to focus on in the next study to see if we can, further elucidate whether applying DBS before dyskinesia is present, does it in fact delay or even prevent it in Parkinson's disease.
Super cool. David, when you visited us at the Brigham, I think you both together visited us in 2023, a key thing you said back then was that for DBS to have this disease-modifying effect, it would need to be applied early, which is, you alluded to this before, and as early as possible. So potentially, if we had a physiomarker even before symptom onset long-term, could be discussed. Can you elaborate a bit more on why that is for us? Like, why do we have to go early?
Yeah, I guess first I'd like to just add on to what Dr. Hacker said and to point out that the 2018 paper and the 2020 paper both had classification of evidence statements that were attached by the editors, and they're incredibly powerful. In the 5-year study, the class 2 evidence was that DBS implanted in early stage Parkinson's disease decreases the risk of disease progression. That is a very powerful statement. It's important also to note that our team does not advocate for that result to change the standard of care. People should not be implanting patients with early stage Parkinson's based on that publication. But that publication does, in our opinion, demand that we conduct the phase 3, and we can get into that more later. Why would that phase 3 have to be conducted in people as early as possible? I mean, it's I alluded to it earlier. It's based on what we know about patients presenting with Parkinson's disease, and it's felt that when a person presents to their neurologist for the first time, maybe a tremor has emerged, a spouse is encouraging the person to come to that visit, we know that they've already lost half or more of dopaminergic neurons upon diagnosis. So that's why we feel that for the next trial, the phase 3, as soon as using MDS criteria, as soon as we're as confident as possible that the person has, in fact, typical idiopathic Parkinson's disease in very early stage, that's the population that we feel is appropriate for the phase 3 study. Waiting until later just means you have further degeneration of the neurons, in fact, that you're trying to protect. So therein lies my rationale for us going, as early as possible.
I just interviewed Jens Volkmann on the podcast, who has I think very interesting results in the animal model that very much support your hypothesis. Part of it is published, part he talked about in the podcast too, and he said, mechanism of action, potentially one idea could be to just give these guys a break. That was his words, these dopaminergic neurons, to give them a break. And because we kind of know these neurons are very complex, they have huge branches going through sometimes big portions of the entire striatum for a single neuron. I think most complex neurons in the brain, if I remember correctly, and they if they become under stress, they might die, right? First. So do you think that is one potential mechanism to essentially give them a break by applying DBS and relieving the ones that are still there from the pressure to perform, or does that make sense?
But yes, potentially so. I mean, I haven't yet heard the podcast or what was said, but the idea that the subthalamic nucleus in the condition of Parkinson's disease has a hyperkinetic output to the substantia nigra, and if that hyperkinetic output is driving neurodegeneration, then could DBS, modulating the subthalamic nucleus, as maybe he said, give those neurons a rest. I think that's a very interesting hypothesis, and And you know, the other one that's interesting, and we can talk about that later as well, is Carol Sortwell's work, where she's shown that subthalamic nucleus stimulation promotes the upregulation of brain-derived neurotrophic growth factor in substantia nigra and also in key regions of the cortex. So, but yeah, and here's what's so exciting to me. Just let's step back and take the big picture. Back in 2006, and from 2000 to 2006, when we were trying to garner the funding to do the original study, invariably the question would come back to mechanism. Well, why would it slow progression? And my answer to that is I have no idea. And furthermore, no one knows why DBS is symptomatically improving patients, but it clearly does. You can argue about what is it doing to provide the symptomatic benefit, and still do we clearly understand that today? But we obviously see our patients get so much better. So
very interesting. So I think I totally agree. We apply DBS without clearly knowing the mechanism. So and I think the one key thing summarizing also from what we've discussed so far is I very much agree, from the evidence we have right now based on your trial, at least we should study it more, right? That's a no-brainer to me, right? It's certainly, if it will be or not, probably we can't say yet, or, it's a single study, it should be replicated, but I think that should be a no-brainer with, us doing Alzheimer's disease, DBS, or depression and so on, where also we don't have, clear evidence of things.
Well, here's here's our thought on what you just said. And while the naysayers are now few out there, they're still there. And as I said earlier, good minds can disagree. Our team feels ethically bound to do this study. And here's why. We filled the literature with class 2 evidence now that DBS applied in early stage Parkinson's may slow the progression, decrease the risk of disease progression, slow the progression of tremor. And so for us to stop now seems to me as an investigator completely inappropriate, right? Yeah. One way or the other, the FDA has approved us to do the trial. We have to complete a phase 3 pivotal trial to answer the question.
Fantastic. And we go more into, future plans, but maybe as a brief small detour, Mike Oken and Kelly Foote, who we heard on episode 25, organize the DBS think tank in Gainesville each year. And as you know, it's a fantastic meeting in which a handful of key experts gather and discuss all things DBS. And in 2023, across the room from me sat Hage Bergman, who was also on the show, episode 17, who started his lecture with a poll that, as I believe, may become historical. And he asked, imagine you have a 55-year-old patient with REM sleep behavior disorder. Would you consider the patient to receive SDN-DBS surgery? And, again, 55-year-old, REM sleep disorder, no Parkinson's. And then nobody in the room of experts, including myself, raised their hands. And I of course, Haggai knew nobody would. This was more rhetorical question. But I somehow suspect that if he would repeat this poll 10 years from now, maybe it would be different. And it's important to unpack this a little bit for the listener. So REM sleep disorder is a condition that is characterized by recurrent dream enactment with excessive motor activity. About 97% of people with that condition will go on to have Parkinson's disease or a different synucleinopathy, which are typically worse options, and within 14 years of diagnosis. So essentially, if you have RBD, you will get Parkinson's or something worse, and a synucleinopathy, very likely. And among these three, if we had to pick, Parkinson's would be the one. So with this high rate of conversion, that's what Hage was driving. If we kind of knew that, and there could be a disease-modifying effect of SDN-DBS on that pathology, wouldn't it potentially make sense to do this? And I was just wondering how the two of you would have voted. You probably also wouldn't have raised your hands, but do you have thoughts on this at the moment?
Yeah,
maybe
so I
Mallory?
can jump in here. Yeah, I definitely would not have raised my hand. As David's already mentioned, we're the first to assert that there's definitely not enough, evidence to even implant a diagnosed patient very early in the course of Parkinson's. We think the pilot, as you've mentioned, has generated more than enough data to continue studying this. So starting from that position, I would not have been supporting this for an RBD patient now. But I do think your question about where would we be in 10 years, I think that's really interesting. Hopefully by then we've conducted the next early DBS trial, a multi-center double-blind study to provide the evidence that the field that we all need to answer this question of whether it is disease modifying. And if so, then, hopefully there are advances in the ability to diagnose the, kind of RBD prodromal Parkinson's, and there's advances there so that we have more confidence that they're going to develop Parkinson's. Then I think, extending our hypothesis, even pre-diagnosis would be, reasonable. But I guess I would also hold out hope that by then we found a more eloquent way to deliver this effect that doesn't require invasive brain surgery.
Agreed. And I would add to that, the point that 97% of people with, REM behavior disorder go on to develop Parkinson's or another synucleinopathy. So Lewy body dementia and multiple system atrophy are also possible outcomes. And as best we understand, DBS does not help those conditions.
Yeah.
So we would be subjecting that portion of patients to the unnecessary risk of DBS. So I wouldn't have raised my hand during the poll and still wouldn't today. But to Mallory's point, if we had a biomarker that, is sensitive and specific for Parkinson's disease, uniquely for idiopathic Parkinson's disease, then that opens up, a new thought in how valuable that will be, obviously, to the field of Parkinson's and all therapies that are being explored, biologics and gene therapy, cell therapy, for disease modification. But, without that, and I also agree, that we wouldn't offer it to them now, just like we don't offer it to an early stage Parkinson's patient. The class 2 evidence is compelling, but it just isn't enough.
Yeah, no, I agree, and I think it was a rhetorical question. Just for the record, Haggai wouldn't offer it to his patients either, but I think he came up with the poll since he's studying the effects of SD and DBS on sleep since a few years, and I think the idea there is that if it helps sleep, this could potentially also lead to neuroprotection. I think there are thoughts about this glymphatic system. Clearing out waste products. Do you have thoughts on that kind of potential mechanism?
Yeah, so I think it's very interesting, right? There's obviously a lot of data supporting the importance of sleep and good sleep quality, not just for overall health, but specifically in the brain. So, asking the question of is SD and DBS improving sleep quality, which could in turn be enhancing the lymphatic system so that it can, in fact, as you said, is it clearing out some of this neurotoxic waste, and is that what's providing this beneficial effect? I think at this point it's definitely plausible. Like I think that's a really reasonable hypothesis, and it actually reminds me of another idea that we've heard many times over the years when thinking about the results that we've seen, which is that perhaps for the people that had slowed progression, maybe they just had really remarkable motor benefit from DBS, such that they were able to lead this active lifestyle. In other words, they're able to just be more active and exercise more. Many people hypothesize that exercise itself could be disease modifying for Parkinson's, and we know that exercise has numerous benefits, right? It also can increase lymphatic function. It also can increase BDNF, which David's already alluded to. So in the pilot, we don't have any data on sleep or exercise. But I think, both of these ideas on potential downstream mechanisms of how this could be working will be important to track. So let's track sleep. Let's look at exercise in the next study to see if we can explore, potentially these mechanisms.
Love it. And then also in the room at the DBS think tank was Alfonso Fasano, who was on in episode 51. And I think he is a fervent critic of the idea that DBS might be neuroprotective. And he argued that as a clinician, he has seen individual patients that left the hospital in a wheelchair after they had gotten a stroke following DBS. So he would speak against it. Do you have thoughts on that, like risk ratio benefit, or also just I think you have been in contact with Alphonse about it too.
Yes, and Tony Lane too, a giant in the field, has expressed similar concerns. I really think that that they're two separate questions, right? And so you can look at the publications, and the most recent connectivity publication from Dr. Hacker in the 2018 and the 2020, and make your own decision about whether that's enough evidence for a phase 3 study. The question of the effects or the risk of DBS, right? This is a therapy that was approved in 1997 in the United States, and so like Dr. Fasano, I have an experience of a patient having a stroke. So in 1996, I was the Vanderbilt PI for the large-scale multi-center trial that led to the first FDA approval of DBS, and we had a patient. We had enrolled patients in that study. One of them suffered a venous infarct perioperatively, and it was apparent that he was not going to be able to survive the stroke that he had. And I sat with his wife, and family brought in pictures of their early days together, and I attended his funeral and had two emotions as I approached the graveside service. One was the duty that I had to be there, and the other was the anxiety and fear of how it would be received by the family. I share that story just so others would know that the risk of implanting DBS is not lost on me. I have a distinct understanding of the risk of the surgery. But that really has nothing to do with answering the question of, if you apply DBS in early stage, could it be neuroprotective? That's the scientific question. Now, here's the overarching point that has to be discussed. The FDA has approved this large-scale phase 3 study. And as I said earlier, the tides turned 95 out of 100. Movement disorders community supports that this study needs to be done. Here's what's so important. It's informed consent. And so I alluded earlier that there was an expanded informed consent process, which has been published, developed by an ethicist here at Vanderbilt. And that informed consent process, in my mind, is the reason that the dropout in the pilot study was remarkably low. Participants understood not only the risk of joining the study, they understood through this expanded informed consent process what it meant to be a participant in a research study, what the implications of their dropping out, understanding that if someone wanted to be in the study with the passion of being randomized to the DBS arm, if they weren't randomized to the DBS arm and they dropped out, that if that happened enough, it would render the results of the study, undiscernible, useless. And that all the people that accepted the risk of surgery, it would have been for nothing, right? And so that informed consent process is key, in my opinion, and it's part of the phase 3 study. We'll repeat that again across a multi-center study. So here's the point that has to be overarching. Patients must have the autonomy to choose to be in a study or not. It is not our place as investigators to say, I've seen a patient have a complication from this therapy, therefore, we will not offer this study going forward to answer the question of could DBS in early stage Parkinson's be disease modifying. In my mind, that would be unethical, to not even allow people with Parkinson's disease to make the decision for themselves through an informed consent process that has been tried, proven, and published to work quite well.
Yeah, no, I totally agree. And speaking for myself, I think if I were diagnosed, I would very much consider it, right? Even if there's just a slight chance of disease modification, down the line it could mean another good year or whatever, right? That is key. So I think there's a lot on the there is a risk side, absolutely, right? And the risks are not minimal. You've said so, Alfonso has said so, but I'm also sure there's a lot on the potential gain side, and it's really up to IRB and FDA to weigh the balances. And I think you've really published everything and went through due process and so on. So I love also the centering patient autonomy, which is the most important factor in everything, to give the opportunity. So yeah, love it. And I would say we move on to the next phase of what you guys did. And Mallory, I think you did visit my lab in Berlin for a few months in 2022 with the idea to look at electrode placement in the original trial, which can of course be a key factor in looking at the effects differently. And this led to a paper in Annals of Neurology and a preprint that is currently, I think, under review. Do you want to summarize what you found? And maybe we can talk a bit about the more local findings first, and then go into fiber tracts if you want.
Yeah, so leading up to that trip and that paper, kind of the reason we reached out to you, Andy, is I had done another analysis, going back to this week-long washout data where we're trying to look and understand, how DBS might be affecting progression. So I had also wondered if we were missing some really potent effect on certain patients on motor progression because we had grouped everybody together based on randomization, which is, of course, what we should do in intention to treat analysis of this clinical trial. But in trying to understand as much as we can from the pilot to best plan the next study, were there some features or characteristics of some patients that might have led to an optimal response? So that led me to do just a very simple motor progression responder analysis, where I just tallied up the number of people in each randomization group whose motor symptoms progressed using that 1 week washout motor score from baseline to 2 years, the people that didn't change, or the people that might have even gotten better. And when we looked at the control group, as expected for early stage Parkinson's patients treated with medications, everybody worsened. It was by, different amounts across the group, but Parkinson's is relentlessly progressive. So this is exactly what we expected to see. But then we looked over into the DBS group, where we saw that 5 people, so fully 1/3 of the people who'd been randomized to DBS, their scores didn't progress after being off of DBS and medications for a week. In fact, 4 people had scores that were better at 2 years than when they started the trial. So it was this finding that David and I were trying to really figure out what was unique about when they joined the study. Were they younger? Did they have a shorter disease duration? Were they the tremor dominant? And none of those questions really kind of pointed us to an answer. This is when we reach out to you to see, if the location of stimulation for this very targeted therapy might be correlated or associated with this progression outcome. And so, it was very fortunate that you wanted to collaborate with us on this, and that you even opened up your lab to me in Berlin for a month a couple of years ago, which was a great opportunity, for my family as well. I got to travel with my husband, and 1-year-old came with me, and we brought this early DBS data set. I got to dive into this question of basically doing an electrode localization study from the pilot trial. And unlike, prior studies where we were comparing to a control group, I think this study is really unique because we're only focused on the DBS patients, right? So any concerns about placebo effect here, patients didn't know where their electrode was, where they were receiving stimulation, or even where we thought it should be. So when we started to look at the DBS patients, as you mentioned, kind of on a local level, looking at active contacts across the group, we saw your typical distribution in and around the STN. But then we asked, like I mentioned, we saw those top responders. We saw people whose motor progression scores were actually better 2 years later. And when we looked at them, we saw that they started to cluster right around the same region of the STN, like right around the dorsolateral region, which has been, characterized and associated with symptomatic improvement for advanced stages of Parkinson's. And as you know, Andy, that was a figure that didn't make it into the Annals paper. We are working to publish that, and it's out as a preprint now. But in the Annals paper, we went a step further to do a more traditional sweet spot analysis, where we wanted to see the location that was associated with the most amount of progression, or the most amount of slowing progressions, the slowest progression rather. And we saw that that location aligned with the Bajani line, which is an established surgical targeting landmark for STN for Parkinson's disease. So we were starting to see that there were similarities between, the location associated with motor benefit, symptomatic motor benefit for advanced patients, but we're seeing these emerge in a cohort of just 14 people with early stage Parkinson's disease, where we're focused on the outcome of progression. Even more interesting for me was when we started to get into the brain connectivity questions, right? So start to think about, okay, well, they see this region of the nucleus, but how might it actually be imparting these disease-modifying effects? So what might be the brain connectivity that could be associated with our slower progressors? And this is where we did the fiber filtering analysis that where a connectivity profile emerged, suggesting that stimulating primary motor and supplementary motor areas, so M1 and SMA, was associated with the slowest amount of progression, or the least amount of progression. And it also suggested that we might want to avoid stimulating pre-SMA region of the STM. So that was a really, cool and interesting finding. It was really a feature of the paper to see that connectivity profile. Since then, we don't yet have another cohort of patients to look at progression. We don't have another early DBS cohort or even another Parkinson's group where we have a good way to track progression, to try to see how well this connectivity profile might hold up in an independent sample. But, we were able to see how this, stimulation paradigm could estimate the variance in long-term motor benefit for standard of care patients. So, there's many people that have received DBS as standard of care patients, and collaborating with David Isaacs here at Vanderbilt, he had a really well characterized group of 29 standard of care patients. So, average disease duration of about 10 years, but he had long-term follow-up data for them. So about 5.5 years of motor scores that we could evaluate. And this is not yet published, but is out as a preprint currently. But what we saw there is that not only does this connectivity profile, but also the sweet spot appears to, predict or estimate kind of the variance and scores that we see in standard of care patients when we look at long-term motor benefit with DBS.
Fantastic, and I think you said a lot of things. Just to unpack it, I was super excited by the first finding already, right, where you see a clustering of the patients that did not progress, and they were all of them perfectly placed patients, right? So, and then the other ones that were more outside, it's really like a donut shape if you look at the figure, right? And that also showed me that the data quality is fantastic, right? This is really study level data, of course, where you put a lot of care into actually get the clinical scores right and everything. And it did cross-validate. Everything was super robust, even though it was just 14 patients. And so that was, I think, really remarkable. But if we talk about that, effect, I think one potential thought could come up that the ones that were placed perfectly, they did not progress as much, but maybe they also had changes in dopaminergic medication. But I think you could show that the opposite was the case. Can you talk a bit about that relationship, right? So, people that did not progress, they had, I think, less voltage, less medication, but optimal placement, right?
Yeah. No, that's something. It's one of the early things. Before we did the electrolocalization study, we were trying to understand what was unique about these 5 people. So I mentioned age and disease duration, but one of the things that we had looked at was, well, maybe they're taking a lot of medications that haven't completely washed out, or maybe they're getting a lot of stimulation, and maybe that is some reason for this. But what we saw was that those the third of those patients, those top responders, had really low levels, greater reduction in levodopa equivalent daily dose, and very, very low stimulation. The entire trial was very low levels, but this group was even, I think it was 1.5 volts throughout the study was what all it took to manage their symptoms. And so we later looked to see, there was this very clear relationship with the people that did really well. They required the least amount of stimulation and the lowest levels of dopaminergic medications to get this robust effect where it looks as if their motor progression has slowed.
Yeah, and you said it before, it's a perfect kind of placebo control that no patient would have known where their electrode was, right? So that seeing that clear clustering there is really, to me, sometimes even better evidence than, without any statistics, you really just see it. It looks like apparent to the eye. So I think that's really fantastic. David, do you have thoughts on the neuroimaging studies?
Well, yes, for me, it is obviously so exciting because having known about, this third of patients that had this remarkable response and searching for why, what's unique? Well, I mean, the credit goes to Dr. Hacker and Andy, the techniques that you've developed that allowed this exploration to finally uncover, if proven in a future trial, this paradigm, in other words, taking this finding and providing surgeons with a preoperative plan to help them get to the location that would give the neurologist the best opportunity to stimulate in this way. And then postoperatively, we can see where the lead is, and then provide the neurologist with a plan for programming a directional lead that would capture M1 and SMA and avoid pre-SMA to get that, potentially get that disease modifying effect. If that proves to be the case, in a large scale trial, then that turns the world of DBS upside down, right? Because avoiding pre-SMA is not because it's causing adverse effects. In fact, it may be symptomatically beneficial, but it's this paradigm of capturing key fibers and avoiding others that, to me, is so incredibly exciting.
And we have talked about this trial a lot, and from 2014, so 10 years ago. So it's been a while since that trial, and I know the two of you have been working very hard to get a follow-up trial off the ground. You already mentioned a few times that FDA approved a pilot, a phase 3 trial. So why was it so hard to do that? And any potential news you can already share about future plans or current plans to follow up?
Yeah. So we've based on Dr. Hacker's work, we've had FDA approval to lead a large-scale phase 3 trial, a pivotal clinical trial, meaning the results could be used to change the labeling of DBS for people with early-stage Parkinson's disease. The FDA has approved us to include 20 centers. They even approved us using centers outside the United States if necessary. We don't believe that's needed. We've had over 30 sites complete pre-site qualification questionnaires and document their interest in being a participant in the study. We think probably we would need 15 sites in the U.S. to fill enrollment and complete the study. So there's far more interest than is needed. Why has it been so difficult to get this FDA-approved study open? Well, it's simply the funding necessary for the trial. It is a very expensive trial. As a phase 3 pivotal trial, all participants are implanted. This model's been used in other DBS studies. All are implanted, and half are activated and half proceed with inactive stimulation for the duration of the time to the primary endpoint. And so all participants have to be implanted as part of an investigational study. And therefore, getting the funding for that has proven to be very challenging. What we've done to try is formed a company, Arena Therapeutics. The idea of the company was to create a venue through which the 3 manufacturers could invest funds to do the study. And the current FDA approval we have, all 3 manufacturers provided us a right of reference. The current FDA approval includes the DBS device from Abbott, from Boston, and from Medtronic. And the idea of Arena Therapeutics would be that manufacturers could invest in the study and they could share the financial risk. In other words, if the study's negative, any individual company would have moderated their financial exposure. So that's the idea of Arena, and so that what sounds like a great idea, just so easy to say it as I shared it with you. Getting 3 manufacturers to work together has proven to be very challenging, and to date we've not been successful with that. However, we have just recently received an angel investment in Arena. We have retained an expert who will assist us in fundraising. We have a second angel investment that is expected actually this week. And so after a period of fundraising and the sort of angel round, we'll issue a Series A of shares and then hopefully open the study for the first cohort of participants.
Wow, fantastic. That's great news. And I think we can mention Todd Langevin, who's also been with your company from the beginning. He was also recently on the podcast episode 46. So I think the aim of the company would be to build the funding vehicle. If successful, is it possible to kind of what would the investors kind of get back, or like would there be patents involved? How does that work? Can you talk about that a bit?
Yes. First, I have to share a quick story about Todd Langevin. So, in 1995 or 6, I mentioned earlier I was the local PI for the Vanderbilt for the Medtronic large scale phase 3 study that got the original indication of DBS. Todd Langevin at the time was the general manager for the DBS business at Medtronic, and the movement disorders meeting was in Vienna, and I think I could take you back to the steps we were standing on, and I asked him, I would like to travel and work, with a team in DBS, and where's the place you recommend? And he said, oh, you have to go to Grenoble. Pierre Pollock and Benabids are the pioneers in the therapy, and it was less than a 10-minute conversation that led to me landing there, as a Fulbright senior scholar, because of Todd Langevin and his recommendation, and he and I have remained in contact. He serves as a board member and founder now of Arena Therapeutics, and has just been terrifically helpful in guiding us. So to answer your question about what's the value proposition, I must confess to your listeners that I do not have a degree in business. I don't have an MBA. I don't have experience, but folks on our team, Todd Langevin, Tim DeLapp, and now Jeff Erb, actually have a lot of experience in the field of deep brain stimulation on the business side. And so here's the value proposition as I understand it. There are really 2 of them. The first is intellectual property. So Vanderbilt University has filed 4 patents for this line of research. One of those patents I don't think is going to issue. 2 of the patents have already issued related to DBS and early stage Parkinson's. The 3rd patent that's been filed is based on Dr. Hacker's work in your lab, and the connectivity profile in the unique way that we may preoperatively target and postoperatively program patients with early stage Parkinson's to get this disease modifying effect. So that patent has been submitted. So there's the IP that has potential value. And then the second piece that would have value is, so you run the study. If it meets its primary endpoint, then the resulting data set of the study could be used by a manufacturer, potentially multiple manufacturers, to gain a change in the labeling that would include people with early stage Parkinson's disease. So that data set, the study conducted by Arena, would be Arena's data, and then it would be, if it had value, would potentially be purchased by a manufacturer or multiple manufacturers to change the labeling. Realizing that in the United States, it's estimated that 90,000 people are diagnosed with Parkinson's each year. thousands more worldwide. Currently in the United States, about, I don't know, 8 to 10,000 people are implanted with DBS, and that number is relatively flat, right? And we have 3 manufacturers, that are competing in a space where the pie's not really getting larger. If there was an indication that DBS in early stage Parkinson's disease slowed the progression of the disease, right, that's a game changer. You now have 90,000 people a year who are being diagnosed with the condition. 90,000 people won't rush out and get the surgery, that's for sure. But some portion of people with early stage will get the surgery. And so how it would impact, the marketplace of DBS potentially is very large. And so those are the two, value propositions for Arena Therapeutics. And as I said earlier, we're not going to quit. One way or the other, our team is going to conduct a phase 3 trial to answer this question. We feel like we can't stop.
I very much agree with you, and as you know, I'm happy to help, and we've had some grants potential together that were also some so far not funded. So it surprised me somehow that it is so hard because of what you just said. It would really have a huge impact on the field if true, right? So also from the industry side, interesting that there's I know you've been in contact with all 3 companies quite a lot, but yeah, it's great that you are persistent, the 2 of you, and like the bigger team as well. So I'm very much commend that effort. I think I've taken a lot of your time already, so maybe we can wrap up with some rapid fire questions, and we can also cover any other points you wanted to talk about in that same process. So I think the first of these typical questions I ask in the end is going to be quite simple for you, but how do you think the field of DBS of the future will look like? Maybe Mallory.
Yeah, I could jump in here first. Stepping outside of our own work, I'm very curious to see what the future looks like and what we can learn about the intersection between artificial intelligence and neuromodulation, right? How can we use this to personalize treatment, improve target identification, enhance programming? Is it going to be useful for adaptive stimulation? I think there's a lot of potential there, but a lot of unanswered questions. So that's more of a curiosity for me to see what comes of that.
For me, the connectivity profile uncovered by Dr. Hacker and the potential to understand, using that technology and those methods in cognition and motor and other disease states. I think that's just, incredible. To answer the question in a very concrete way, I think the field of neuromodulation and what the future looks like is that DBS will be proven to slow or stop the progression of motor symptoms in people with Parkinson's disease if applied in very early stage.
Fantastic. Eureka moments in your career when you thought, I can guess some, but maybe you can talk about that as well.
Yeah, I guess I wouldn't consider any true eureka moments because this is all preliminary and hasn't been proven yet. But, we've already talked about the tremor finding. But for me, the biggest one was seeing that relationship between stimulation location and slower progression, right? Is this the reason why, in that 2014 paper, if you look at the intention to treat analysis, the difference between the 2 groups, there wasn't this huge dramatic effect size for the DBS group that we all, many advocates would have hoped to see. And so is it because this is a very targeted therapy and you need to precisely apply it in order to get that effect? So I think that's really, a eureka to generate a hypothesis, right? That's given us a very concrete hypothesis to test moving forward, which is really exciting.
And maybe to briefly expand on that, I think it's such an important topic here because we use trial designs from pharmacotherapy, right? We give a medication in one group, we don't give it in the other group, and then we look at the differences, right? That's just the established model. So for clinical trials with DBS, we do the same thing, but the difference is that in the DBS arm, so in the active arm, the dosage could be very different based on electrode placement, right? And most clinical trials don't look at that, and it's not in the design. It's not, and I've been, same applies for, I would say, depression, Alzheimer's disease. All these trials, including some of the failed trials, could have been just because not all patients had necessary dose in the DBS arm, right? So I think it's such an important topic where, as a field, we should probably discuss this more. Is this the right way to do this, or do we have to, there are concepts where you'd say, okay, you localize the electrodes and only the people that actually have a right placement get enrolled into the DBS arm, or maybe that's necessary. So I think it's a really good point that you raised there. Yeah, David.
Yeah,
Eureka moment. So yeah.
Yeah, for me, I mentioned, being in the dressing room after a DBS case, and Professor Benabids suggesting that he felt that DBS applied early would slow the progression of the disease. The eureka moment for me would be, looking at the videos and seeing, at least thinking I was seeing what he was talking about. Like, wow, could this be? And going from being the skeptic as he was sharing the story to like, wow. The other one I'll share is, Mallory Hacker's 2018 publication, that DBS in early stage Parkinson slows the progression of tremor. I remember when she discovered that and came to share the data with me. We went for a walk on Vanderbilt's Peabody campus. It's a beautiful lawn. And I remember the two of us standing there and thinking, wow, this is it. This is the first finding, and sure enough, when the publication came out, the editors attached the classification of evidence statement to it. That was clearly a moment for me.
Yeah, no, that's really fantastic. And did you, by the way, since you mentioned Dr. Benabid one more time, did you ever go back to him and essentially had a call on this, or or emails on?
Oh yes. No, he's visited Vanderbilt at least twice. He came. We had a big celebration when the pilot study was finally concluded for all the team that participated in, all the participants, their spouse, their family, and he was the keynote speaker for that study. And he has written numerous letters of support and grant applications and such. And so
he knows, and he's a fan. Or yeah, he's a supporter. Great. Yeah. Any time where you thought, either one of you, this was a big waste of my time, this didn't go as planned? Hopefully Mallory doesn't say the trip to Berlin. But any time in your career?
Not at all. That was a wonderful way to spend my time. No, I don't have anything notable and worth mentioning here at this time.
David? Because it's always good to also talk about the more negative things and just not the successes. Also for maybe trainees that would listen in, but yeah, anything you want to share.
I guess if I expressed a frustration and maybe a smarter person could get it done faster than me, it's just the time it's taken, right, to garner the funds to do the pilot. We'll eventually get this phase 3 study approved, but the time that it takes to get there, and so that in some sense feels that lost time feels wasted to me, because there are people with Parkinson's disease that are suffering, and we need this answer. And if the answer is negative, then that helps us, because right now I'm aware that people who are wealthy, as sort of one-offs, are paying for DBS to get it early, right? We may learn from this phase 3 trial that DBS in early stage is harmful. Not what Dr. Fasano was talking about, that there could be, a brain bleed or infection, but that stimulating people in the early stage causes some unforeseen consequence in the brain. So that's why we're so adamant that the phase 3 has to be done and to answer the question. And it could be the answer is to protect people from getting DBS in early. But on the other hand, if it's shown, in fact, to be disease modifying, then what a waste of time we've had over these years. From the time the FDA approved the pivotal study until the time it's going to be completed, and the people that have suffered there. Any advice to young investigators is persistence. I remember a mentor once talking about a colleague, and he said, he never spins his wheels in one direction long enough to get anywhere. And that advice really stuck with me, maybe pathologically, because we've been at this a long time, and I'm not going to stop. We're going to continue and be persistent. Would be my advice to a young investigator. Latch on to the questions that you want to answer and follow through and be persistent.
Mallory, any advice for young folks from your side?
Yeah, I think it's really important and maybe not discussed often enough to work on early and often in your career, your scientific writing, right? So when I was a graduate student, I had the opportunity to kind of lead and write my own grants, and that really kind of set forth, some of the successes that I've had. It's so important to articulate the importance of your brilliant ideas if you have them, but if you can't do that, it makes it so much harder. So I think, taking opportunities to work on your scientific writing is really important to do early and often.
Any advice for women in academia?
Yeah, so my answer here stems from recent experience. It's obviously important to have a supportive environment in your career and at work, with surrounding yourselves with great mentors and a good, environment academically. But I think it's, equally important to have a supportive environment at home. Like I said, I've recently become a parent, so this is very top of mind for me. But I'm very fortunate that my husband Henry, who himself is a very successful in what he does. He's a rock star in his career, but he has always been all in on my career, and recognizing the importance of the work that I do, and we prioritize that. And so while I've always known that he supported me in my career, this has become, very apparent as we became parents the past few years. So he, has really alleviated some of what could have been added stress by, being wonderful at sharing parenting responsibilities as much as biologically possible. Because, adding parenthood and that work-life balance with an academic career can be very challenging. And so having that equal partnership at home and support for your career, I think really goes a long way in preventing burnout and keeping you moving forward.
Sounds great. Yeah. We have talked about the future of the field already, but and you, David, have alluded to missed opportunities. We may be wasting time to help patients. Do you think there are other, maybe more globally thinking about DBS, missed opportunities, things we should be doing more but are not as a field? It could be, in this context or below, beyond.
Yeah, I mean, I was ready to chime in with something very similar to what David said. I mean, obviously we are so laser focused on this. It's hard to think more broadly, but we need to answer this question. And so for us, this remains a missed opportunity for us as the research team trying to answer this question.
Any topic you would have liked to discuss, or anecdote to share, anything that I missed? I know I took a lot of your time, but if there's anything else you wanted to briefly mention or mention at length.
Yeah, I've got one. We didn't get into this at all, but I think, as we think about, this next study and the opportunities that we have, really a potential, the opportunity to leverage new technologies. And one of the things that would be really interesting to look at is whether there's a physiological signal that could be used to inform this optimal location for disease modification. Obviously, we haven't looked at this directly from the pilot, which was conducted, almost 20 years ago. But it's plausible that there's overlap with beta power, for instance, with kind of where we want to be stimulating. And so this is just another example of, the data from the pilot is so exciting for us, and the opportunity to apply, new and emerging technologies to try to best answer this question. It is really, exciting for us.
That's a great point. So adaptive DBS, or the sensing field of DBS, could of course help make this a success. David, any thoughts you wanted to bring up?
I don't think I have things further to add. Just a huge thank you. Andy, thank you for including us It's been just a joy to visit with you.
Thanks so much. It's been a big honor. I think this is a very interesting episode for many people that are interested in DBS, and I hope it will raise some awareness of the fantastic work you've been doing and are doing. So congratulations, and thank you for joining the podcast.
Thank you, Andy. This has been a great opportunity.
Thank you.